Good evening, ladies and gentlemen, and welcome to the Polsky Practical Personal Enrichment Series, where topics are presented that aren't being offered anywhere else, where successful local professionals share their knowledge to benefit you. I'm Emily Bierman, and before we get started, if you would silence your cell phones or pagers or other devices you have on your person so we don't disturb people in the audience this evening. Thank you. And before we move ahead, I would like to recognize Jerry Cook, one of the trustees of Johnson County Community College. Jerry? Up in the back. Thanks for coming tonight. The Polsky Practical Personal Enrichment Series is underwritten by the Norman and Elaine Polsky Family Supporting Foundation within the Greater Kansas City Community Foundation in partnership with Johnson County Community College. Norm and Elaine's name graces this theater, and we thank them for their generosity, which also brings you the Polsky series. Norm and Elaine support organizations across Kansas City and the nation, enriching our community and communities around the world. And at this time, I'd like to acknowledge Norman and members of the Polsky family that are with us tonight. Thank you, Norman. Also, many thanks to our JCCC TV and Carlson Center production crews for their assistance with tonight's program. You'll notice that we are taping for broadcast, and you can find us on Time Warner and Shore West Channel 17, Comcast Channel 22, or you can watch us online at video.jccc.edu, anywhere 24 hours a day if you choose. And now let's go through the packet that you were given when you entered the theater tonight. This is for you to take home and share with your family. On the right-hand side, there is a blue question card. So if you have a question during the presentation, please hand it to one of the ushers. I'll be walking around. You can hand it to me, and we will collect those and then bring them to the podium to pose them to our speakers later in the program. You also have a green survey card, and this is for you to give us feedback on the program. If you'd like to add yourself to the mailing list, if you don't currently receive our mailings, you may do that as well. We also send notifications of this program via email, so if you'd like to give us your email address, we can send it to you that way. And you may have noticed this time, we are no longer going to issue tickets for the Polsky series. It's just going to be a come-as-you-can free event, so you won't need to call the box office for a ticket or reservation in the future. So you'll need to get on our mailing list by filling out the card. Behind the cards are handouts that will be used in tonight's presentation, and you can see that tonight's presenters are David Wilson with AARP Kansas, Elaine McIntosh of Kansas City Hospice and Palliative Care, and Natalie Schneider. On the left side of your packet, I'm not going to spend a lot of time on that side anymore because our speakers will cover that. But on the left side, a flyer about the next Polsky seminar, which is June 2nd. It features Adam Bold. And this reminds me, we do have Mr. Bold's books for sale in the lobby tonight for $10, the 10 Commandments of Investing. And, you know, if you'd like to take one of those home this evening, you can read it before the next program. And when you come back to see Adam Bold, you can ask the really tough questions. So you may want to pick one of those up. We also have Harry S. Truman, The Man Who Walked with Giants. Again, only $10 in the lobby tonight. This is a fabulously illustrated book and full of great historical information. And these make great gifts for you or for your loved ones. Also on the left side of the packet, on pink, this is Norman's investment article. This one is dated April 2nd of 2010. If you'd like to receive Norman's articles in the future, please send him 4 self-addressed, forever stamped envelopes, and his home address is on the top of each side of that pink page. On the green sheet, there's information about Reaching Out from Within, an organization founded by Sue Ellen Freed, which emphasizes kindness. And on the back of the green sheet, some quotes about kindness. And then behind the green sheet on white is information about Alexander Davis, MD, who participates in a new program called Etiquette Medicine. Norman recommends that anyone over 80 years old participate in one of these etiquette medicine programs, and we'll talk a little bit more about that later. This is what has worked for Norman, and so it's something that he wanted me to share with you. There's also a flyer there about home care medical equipment, and the reason we've included these 2 flyers is, as always, because Norman asked us to share this information with you, and he also asked me to tell you a little bit about his current situation. Norm and Elaine Polsky established this series so, obviously, that local professionals and organizations can come share their knowledge to benefit all of us. And in the past few months, Norm and Elaine have experienced health problems themselves, which makes this evening's program especially relevant to them right now. Norman and Elaine believe that their recent experiences belong in this particular Polsky seminar, and they ask that I share the following information with you in hopes that it will help you make decisions about your health care or that of a loved one. Elaine Polsky is 84 years old. Don't tell her I told you. She lives at Village Shalom Retirement Community right now. Norm wanted me to tell you the cost is paid with a combination of Medicare and long-term care insurance. Elaine suffers from a condition currently that causes her great pain, so she has gone to Village Shalom to seek treatment for that. Village Shalom furnishes a lot of other things as well. Nurses and assistants around the clock who can monitor her care and her medication. Elaine has so many friends at Village Shalom that she's able to see every day, and she can choose to attend events or participate in activities while she's there. And she also receives physical, occupational, and speech therapy. And as all of you probably know, Norm Polsky, who is 86, and he said I could tell you that, Norm has a history of working all day, every day, all the time. And recently, Norm has been in and out of Menorah Hospital, where he was suffering from exhaustion and complications from congestive heart failure. He's fortunate that he has the resources that allow him to stay at home, and he does that so he can keep up with the work that he wants to do every day. He's lucky that he can afford the cost for American home care, and that's a few $100s per day. Medicare covers a visiting nurse that comes by every morning and keeps Norman's doctor, Alexander Davis, informed of his blood and protein count. And this data is important as Norman takes Coumadin. His goal is to prevent another stroke like the one he had in 1994 when he lost partial vision in his left eye. Norm's supplied at home with 2 tanks of oxygen every day, every week, paid by Medicare and supplied by a local home care service. And Norm also wanted me to share with you he has sleep apnea, so that requires a special CPAP machine and face mask, and some of you may experience that as well. The Polskys are fortunate to have the resources to arrange for the care that they need, and they realize that in most families, one option is to have your elderly parents come and live with you or you and your grandchildren, and sometimes that can be very difficult. But in the end, all of us want to provide the care that will keep our loved ones as comfortable as possible. So we hope that tonight's program will be of help to you in making those decisions for you and for your family. So now let's turn it over to David Wilson with AARP Kansas. Thank you.
Thank you very much. I want to add my thanks to the earlier comments, to thank Norm and Elaine Polsky for having this wonderful opportunity to inform and have dialogue on this very important topic about health care. Norm, it's great to see you here, and thank you so much. Well, today I'm going to give you a real fast infusion, if you will, about the new health care law with an emphasis on people that are 50 plus. As I'm over 65, I guess this also concerns me. But first let's talk a little bit about AARP briefly, our philosophy. The lady you see pictured there is Ethel Percy Andrus. She, in effect, established AARP, and she has a wonderful quote. She said, "What we do for all," and that's really part of the main reason why I volunteer for AARP. As the story goes, back in the mid-1940s, she was a school principal in Los Angeles, getting ready for retirement, and she went to see a friend. That friend was a retired teacher, and she was shocked when she went to see her because she was living in a chicken coop. Now, you know, teachers back then had no retirement, there was no Medicare, there was no health insurance, and she was appalled that her friend had to live this way and could not afford good health care. So she went out and formed this organization, the American Association for the of Retired Persons, AARP, and it was initially for teachers, and then gradually it expanded. But with this main early on focus to establish health care for older adults. So that's where we came from, and I think it's a legacy, and we say what we do for all, and I think that's important. Our mission, AARP is dedicated to enhancing the quality of life for all of us as we age. We lead positive social change and deliver value to members through information, advocacy, and service. We're fighting to protect a number of different issues. We're fighting to protect Social Security. We're fighting for rules and fighting for quality legislation regarding banks and financial security. And because of our mission to advocate for older adults, and particularly those people who have no one to advocate for them, after careful analysis, AARP fought for health care insurance reforms that will benefit our members and all Americans. Now, I understand there's a lot of confusion, and there's a lot of inaccurate things being said. I'm sure all of you have heard about the death panels early on that were just so totally false, it was ridiculous. But, in reality, Americans have heard too little about what this will mean for them and their families. According to a recent poll by the Kaiser Family Foundation, 55% of the respondents say they are confused about the law, and an equal percentage say they don't yet have enough information to understand how it will affect them. So I'd like to talk to you today about some of the highlights of the new law. And again, these are highlights. This is a very wide encompassing law. Many are saying that this is equally as big or bigger than the bill and the act which established Medicare. So let's begin. Let's talk about people who are on Medicare. Now, as we talk about this, remember, the bill does not have all the specifics in it. The bill lays out a broad general plan. A lot of the specifics are formulated in administrative rules and regulations that carry out the requirements of the bill, and a lot of those are still being written. So as I give you information, there's still a lot of blank spaces in there, and as we get towards the end of my presentation, I'll tell you how to keep up with all this information. Now, if you have Medicare, and I'm going to say this loudly and boldly, your guaranteed Medicare benefits are protected. Let me say that again. If you're on Medicare, your guaranteed Medicare benefits are protected. If somebody is telling you otherwise or that they're going to shut down Medicare, they're way wrong. You will, in fact, receive improved benefits. For example, there'll be improvements to lower your out-of-pocket costs for prescription drugs, and we're going to talk about that, the donut holes they call it, in a little bit. And also there will be more and increased benefits for preventive services, diagnostic testing, these kinds of things that will help keep you healthy. Another point to remember relates to the extending of the long-term financial health of the Medicare program. A lot of people don't know this. This is going to extend the life of Medicare. Medicare was in deep, serious trouble prior to the passage of this bill. According to official estimates, cost savings like those being achieved here should keep Medicare financially stable almost a decade longer than if the new law had not been passed. Also, over 10 years, the bill reduces the U.S. deficit by an estimated $143 billion. An estimate by this was provided by the nonpartisan Congressional Budget Office. As we mentioned in Medicare, there is some very, very important new free preventative and wellness benefits have been added. These are mammograms, bone density screenings, colonoscopies, annual checkups. It used to be that when you signed up for Medicare, they gave you a kind of a welcome to Medicare checkup. Haven't gotten mine yet, but I presume I will. But now you get an annual checkup under Medicare. Some very, very important things that are happening there. There will be new benefits that will apply to both original Medicare and Medicare Advantage plans. And the thing to realize, though, as we move through this, a lot of these benefits are phased in between now and 2014, so everything doesn't happen all at once. There's a booklet in your packet that has a lot of information about the phasing in of these. Let's talk a little bit about prescription drugs, because this is at a very, very important change in this bill, and one that I think affects an awful lot of people here today. First of all, let me talk a little bit about terminology. Do you all know what a donut hole? How many of you have heard about a donut hole? Okay, you know kind of what this is about. Let me just give you a summary of the way the bill is right now, or prior to the enactment of the new bill. The donut holes, we call it, is when people with Medicare Part D, that's a prescription drug plan, reach their initial plan limit, which is $2,830 in 2010. So under the old plan, you reach this limit of $2,830, and then there's a gap in the coverage. Your coverage for your prescription drugs stops. That's what they call the donut hole. Somebody said, well, it's a bagel hole or whatever it is, but it stops. Your coverage stops once you've paid out, once you have gotten $2,830 in benefits. Now, when you are in this coverage gap, you have to pay all of your prescription drug costs. There's no benefit. When your total costs reach $4,550, that's $4,550, you only have to pay a 5% of the prescription drugs for the rest of the year. So it's kind of a funny kind of a insurance program, not funny, ha-ha, but funny, odd, that it pays your benefits up to a point, stops for a while, and then picks up at an even greater level. But a lot of people are stuck when they get to that. They're having to pay out a lot of money for prescription drugs. And a lot of people don't have it. And we hear stories about people, taking less prescription drugs or not taking them at all. Now, those of you now under the new bill who reach Medicare or have Medicare Part D, that's a prescription drug plan, this donut hole, if you enter the donut hole, if you're spending it so much for your drugs that you enter that time where you're not getting any benefit, this year you will automatically get a benefit of a $250 check. And you say, wow, that's not very much. Well, it isn't, but it's just a temporary benefit. Because over a period of time, actually by 2020, that gap donut hole will be completely closed. Now, if you reach the donut hole next year, you'll receive a 50% discount on brand name prescription drugs and a 7% discount on generic prescription drugs. So a year from now, it's going to start closing and getting better and better, and then ultimately it will completely close the donut hole. Now, I do need to caution you, and I don't think I need to tell most of you this, there's a lot of scammers out there. There are people that are coming and saying, well, you've got to sign up with us in order to get your extra money to help that $250 benefit. No, you don't. So be real careful about people when they come and make different offers for you. Okay, let's talk a little bit about Advantage plans. Medicare Advantage plans, sometimes they're called Medicare C, are another alternative for you as a packaged Medicare benefit plan. There'll be new rules that will stop Medicare Advantage plans from charging people enrolled in these plans more than original Medicare for certain services. This includes services for chemotherapy administration, renal dialysis, and skilled nursing care. Medicare Advantage plans that provide you with better quality will receive additional bonus payments. And finally, Medicare Advantage plans must limit the amount they spend each year on administrative costs. They want that money to go back as a benefit to you. Again, we're still talking about people that are on Medicare, reducing waste, fraud, and abuse. Folks, this is huge, and it needs to be closed down, and I know they're going to work hard on this so that Medicare can remain financially viable. Now, let's talk about one of the things that has created problems, particularly in this economy, is that people that are in the age from 50 to 65. When you reach 65, at least you have some recourse. You can go into Medicare, you can have prescription drug plans. If you are very low income, you can go get into Medicaid. There's a lot of resources to help you get medical care. But if you're 50 to 65, you are in a world of hurt if you lose your job, if you lose your corporate benefits, and we got a lot of feedback from that group of people, the 50 to 65. As you know, AARP, its membership is open to people 50 plus. So we saw a really important opportunity to advocate for people 50 to 65. So it does protect early retirees' health coverage. And with this particular instance, I'm referring to if you have retiree health coverage, the new bill offers federal funds to encourage your employer to keep you on those plans. The biggest part of this, though, which will affect a lot of people 50 to 65 and younger people, is a plan to allow everybody to have health care insurance. Very controversial part of this bill. Everybody must have health care insurance. The reason for that is they wanted to make sure that everybody is covered, because one of the biggest problems is that our costs for health care have been going up and up because the people that have health insurance were paying for the people that didn't have it. And so by having everybody have health insurance, we're not only ensuring everybody quality care, but it should help lower the costs. Now, if you don't have insurance or buy your own cover or own a small business, you will have access to health insurance under this new act. You can get coverage even if you have past health conditions that has prevented you from getting or affording insurance. This is the issue about pre-existing conditions. Those without insurance will be able to buy private policy through purchasing pools called exchanges. These are being created between now and 2014. They're set up in each of the states, and they will be a marketplace for you to go, compare, and purchase quality health insurance at affordable rates. And all this is, there's guidelines in the Act about how to make that affordable. There are guidelines that says you can't discriminate because of a pre-existing condition. There are guidelines that control things like heretofore insurance companies charged more for people who were older, sometimes more for women, sometimes more for people with pre-existing conditions. All that's going to change now with this new act. So you'll be able to go to these purchasing pools called the exchanges. They're run through the state, so they're very localized and controlled through the state insurance office. People who are without insurance, small business owners, people who are self-employed, will be able to purchase health insurance through these exchanges. But again, the flip side of that is you'll be required to have it. Now, what if you can't afford it? What if you can't afford health insurance through the exchanges? There will be extra assistance available depending upon your income for you to be able to afford health insurance through the exchanges. It'll create a one-stop shopping for health insurance. All the plans in the exchanges offer a standard set of comprehensive benefits. The benefits will include medical, mental health, prescription drug, and rehabilitative services. You'll be able to pick from 4 levels of coverage to fit your needs. So, and again, these exchanges will be available, and you can pick a coverage that will suit your particular need. For people who are uninsured or buy their own coverage, to make this coverage through the exchanges more affordable, you'll get tax credits to help pay your premiums for health insurance you purchase through the exchange. If the income levels are less than $58,280 for a couple or $43,320 for an individual, there'll be additional benefits. Many people will be eligible for Medicaid. They're widening out the eligibility for Medicaid. This is, again, the state and federal program for those who have very low income. All children, parents, and childless adults who have limited income but do not have Medicare will be able to get Medicaid coverage starting in 2014. Kids have also been an issue, and again, we're looking at a little wider picture, but we're also finding out that older adults many times are responsible for grandchildren. So this law extends, also, one very important thing is this law extends coverage for your adult children up to the age of 26. Now, that may not apply to you because maybe your children, mine certainly, are older than that. But it will allow parents of the children to keep them on their policy till the age of 26. Increased protection for consumers. This is something that AARP has really been pushing for. By 2014, insurance companies will be barred from denying you coverage, even if you've been sick or disabled. These are often called pre-existing conditions. Protections will be put in place to curb excessive premium increases because of your age, gender, and health condition. Discriminatory insurance practices are going to be a thing of the past. Starting this year, as long as you pay your premiums, health insurance companies can't drop your health coverage if you become sick. Really important. Beginning in 2014, you can't be denied health insurance because of a pre-existing health condition. As these things that will go in, these will be gradually put into place beginning in 2014. A lot of policies have something called lifetime limits. Sometimes they say, oh, $1 million. I've seen that a lot. You know, lifetime limit of $1 million. You can go through $1 million, folks, with several serious conditions. Lifetime limits on your coverage will be banned starting this year. The law will begin phasing in restrictions on insurance companies from using arbitrary annual limits on your coverage, and by 2014 they will be banned altogether. There will be no limit on the coverage. The policies are required to have, like Medicare, to have provide free preventive care benefits. One of the ways of reducing health care costs is to ensure that people get all the tests that they need in preventative care so you don't end up in the hospital. So this is another very important part. Preventative care is a really important part of things. Let's talk about one other little feature most people don't know, long-term care. This particular act provides for a private long-term care insurance plan. It's voluntary. It's called CLASS, C-L-A-S-S. The CLASS Act stands for Community Living Assistance Services and Supports. It's a voluntary program. It can be administered through the various employers, or you can contribute to it directly. You will pay a monthly fee, and if you pay for at least 5 years, you become vested, and it will pay estimated between $75 and $100 a day for as long as you need it. And I say for as long as you need it. That means for the rest of your life if you need it. It's the first thing of its kind, and it's brand new. It is a totally private offering, but it will be available to everybody. Regardless of wherever you work, regardless of your health condition, you will be able to get long-term care insurance. Also, in terms of providing more and better information, the Medicare is going to beef up and even improve even further its nursing home compare tool. There is, at the Medicare.gov website, a place that you can go and look at different nursing homes or senior communities and see what their records are and get an idea of whether this is a particular facility that you might like to have. Another important thing that I think is really important, if you're married to someone with Medicaid, who's on Medicaid and receiving care services at home, you will have the same protections for your income and other resources to spouses of those on Medicaid who live in nursing homes. Some of you may know this, that if you have a spouse, say, in a nursing home, there are some protections, some division of assets that can occur so that the other spouse who is not in the facility can continue to live, hopefully, a normal life. That did not apply to people who are on home health care services. That's going to change. It will now apply to people who are getting services in their own home. You should know that AARP firmly believes that seniors ought to have and have to have the right to determine where they want to live. And people are telling us they want to live at home. We fully support that. So this is a really important benefit. Also, there's other provisions of the bill to expand and promote independent living. There's something called the Community First Choice option that some states are offering that will be expanded. Finally, and I know I've zoomed through this, resources. At AARP, I can't tell you enough. If you haven't been to the AARP website, www.aarp.org, get the facts. Just go to AARP, Google AARP, and you can go there, and there's lots of information there. Medicare, Medicare.gov, lots of good resources there. The Kansas Insurance Commission, or Kansas Insurance Office, has lots of important information about Medicare on its website. And there is a section on the Aging Kansas website called the SHIC program. And that is a program that it's called the Senior Health Insurance Counseling for Kansas. If all this confuses you, and it does me, the SHIC program, which is administered through the Department of Aging, you can get it at this website, and they will help you understand and work through the selection process of selecting and finding health insurance. So, normally I take questions here, but we're going to wait and do the questions at the end, so I'm going to skip over that and say thank you. I know this is complex. It would probably take me 20 hours to go through all the pieces, and they're still not all there. So I think that this will be significant. I think it's going to finally allow people who don't have insurance to have it, and I think it's finally going to help people on low income who have been suffering without adequate medical care. So thank you.
That's one of the best overviews of this I have heard. So, David, thank you very much. As David says, there's a lot more to this, but that was great. Let's see. I'm going to do a high-level, Natalie said earlier, flyby on the complicated subject of getting ready to take care of someone, yourself, or someone that you're responsible for in their older years. And I think of this process with a shorthand that I call ready, set, go. And that's intended to apply that this really is something that you can and should prepare for, but that at some point something is going to trigger putting in place some of the things that you've thought about. So in the getting ready section, and I will say, just digressing for a moment, that getting yourself educated, like attending this kind of a program which Norman and Elaine Polsky make available, is a huge part of this getting ready. And there's so many people who don't learn anything about this until they're halfway into a major crisis that I'm delighted that you all are here and tuned into this. But in this first sort of phase of things, if you will, and ideally when you're healthy, the first thing to really do is to face facts and to realize that the vast majority of us are going to be infirm. Unfortunately, few of us are going to be walking around one day and suddenly, functioning at full tilt and gone the next. Most of us are going to have a period where we're dependent upon people, where we're going to need someone else or many someone else's in some instance to help us get by. So I think that there is, quite honestly, a lot of denial about that reality, but it is true. That is, for most of us, the future. And so it's important for us to do as much of our own planning as possible. If you don't plan for your own care, someone else will end up making those decisions for you. And in some respects, if you want to be the decider about what things are, how your life is going to be at that point, it's important that you do the advanced thinking and that you do the advanced planning. The financial side of this, of course, is huge. The legal aspects, your will, your trust, titling property, all of those things are, in some instances, relatively straightforward. Co-titling property makes it infinitely easier to transfer an automobile, a piece of real estate, etc. But it's so much easier to think about and so much easier to accomplish when you're up and about, clear-headed, and all the rest. durable power of attorney for health care is one of the most important documents that I think that most of us can ever have. Now, many of us won't ever need it, but the durable power of attorney is the document which says, if I'm incapacitated, this is the person I want to make my decisions for me. That, to me, is a much more important document than what is called a health care treatment directive, which is the document which generally sets forth the type of care that you may want to have. And in the packet tonight is that document, which is provided by the Center for Practical Bioethics. And the one side of it is the durable power of attorney. The other side of it is the health care directive. And you can just put an X. If you only want to do one of those, you just put an X through the other one. But those are important things to have on file and to give copies to of the people who really need to have that, your physician, your family, etc. Power of attorney for financial matters is also important, and it's also important to realize that both of those trigger, or they're generally set up to trigger, only when you are unable to handle your own affairs. Obviously, in the ready department is considering what living arrangements you may consider. And it's a broad topic, obviously, who you live with, where you live, when you may move out of your two-story house with all the flights of stairs, etc., whether you will move in with a relative or someone else at some point. But all of that stuff is so much easier to contemplate in advance rather than when you are in the moment and others around you are trying to think this through. Set. Okay, the second part of this is really about communication about what you want. We use this phrase, have the talk with your family, which means talk about what you want, how much aggressive care you want, how you feel about certain types of medical technologies, respirators, etc., how much really aggressive life-extending treatment that you want. And I've just been thinking about this lately, and I think sometimes maybe the idea of having the talk is a little, it doesn't fit with everyone. I think the important thing is find a way that is comfortable for you to talk with the people who are closest to you about these matters. And it may not, it may be around a movie. It may be around something other than a sort of serious, now it's time we're going to sit down and talk about this stuff. But it's important to find the right way, the comfortable way that you can communicate about these matters. It's also important to do it repeatedly. Really, this is something that is, it evolves over time, and it deserves a couple of times a year this subject simply getting on the table. So I think it really is important to do this repeatedly, to talk about what you're hoping for. Financial matters, especially as they are going to impact your care. Now, a lot of people are very private about their finances. They don't want their children to know how much money they've got. They don't want their sister, if their sister's the person who's going to be taking care of them. We're very private about our money. But there is a certain reality to this, that if you do reach a point where someone else is going to be handling your financial matters and your care for you, that something about the financial parameters are important to be shared. Desires for end of life, burial, all of that, someone needs to know what you want. Then the go part of Ready, Set, Go is the triggers. Generally speaking, as is obviously common sense, something happens which causes the circumstances to change. It may be the death of a spouse. Oftentimes a couple are able to collect together, manage to sort of keep things glued together. But when one of them is gone, it throws the equilibrium off, and the other person is really not able to be alone anymore. An acute illness, a serious fall, a disease, a scary experience at home, loss of friends or neighbors, support systems, etc., driving, lifestyle changes, difficulty handling bills, nutritional concerns. Something usually triggers a change, and you know you are in a new situation. Within all of this is also the emotional aspects of this. And I want to just speak for a moment about when this is going on, the part that sort of reaches you. There's a very practical side of this, but there's a very emotional and painful part of this as well. This is not an easy time of life. And aging does bring multiple losses. It brings loss of friends oftentimes, your own level of function and independence, and I think that simply acknowledging that that is a reality is an important part of this. The other issue about aging and increasing dependency is an emotional issue as well. But I think that there are things that can be done. If the individual who is losing their independence is empowered to participate in the decision-making as much as possible, it helps enormously. It also helps enormously when you move through various stages of caregiving to establish new routines. Routines give normalcy and stability to life. So simple things like, instead of, okay, I'm the daughter, and I say, Mother, I'll be by twice a week. Instead of Mother, I'll be by twice a week, Mother, I'll be by at Tuesdays nights and Friday mornings. It's a routine, it's established, it feels normal. So establishing a new normal is an important thing that can be done. And I think the other thing is to just recognize that when people are going through these changes, everybody's grieving. I mean, if you're taking care of your parent, you are grieving the change of that person's role in your life. And your parent is grieving the loss and changes in their life. Then I want to also mention just briefly long-distance caregiving, which is increasingly common as we are such a mobile society. If you are an only adult child, for example, and you've moved to Chicago and your mother or your father or whomever is still in Kansas City, it's a very challenging role. But And so it's important to really get organized. And the first thing to do is to identify who your people are, who is your local team, and who is going to do what. Identify what the problems are that need to be done, what the goals are. Realize that when you are out of town, problems may be hidden, and conversely, they may be exaggerated. It's very difficult to know sometimes what you are hearing when you are on the other end of the phone, and that's very much the case when you are out of town. Thinking about a move, obviously, balancing the elders' rights with issues of safety. Many older people are really happy. They want to stay in their own home and take certain risks. And people who are of sound mind obviously have every right to make those choices for themselves. But there is a tension here between honoring someone's choices and realizing that they have the right to make their own decision, and between keeping them safe. Also considering that the family dynamics which have always existed, how communication occurs, and what happens when there's both out-of-town family and in-town family. Now, those of us who are in the caregiving world know there's a phrase we use, the daughter from California has come back. So, okay, so everyone that's local is managing this day to day, week to week, observing what is happening. And the daughter from California, who hasn't been here for several months, flies in one day and is utterly appalled by what she sees. It's disastrous. You're doing everything wrong. I'm here to fix everything, et cetera, et cetera, et cetera. This is really a very common and very understandable kind of situation. So it's important when you do have a person in the family system who's out of town, that people understand, first of all, the local people understand that what happens when you're from out of town and you come in and you see this and you haven't watched this day to day, week to week. And conversely, the out of town person needs to really respect what everybody who's been in town rowing the boat has been up to for all this time. If you are the caregiver in this situation, and increasingly as our caregivers are old too, we are all living a good long while, and the oldest group of us, the fastest growing group of us are those over 100, I understand. So we may have, the 100-year-old being taken care of by the 80-year-old being taken care of by the 60-year-old. But there are obviously things and challenges for the caregivers to face. Fear of losing your own independence, your time, your financial resources, disruption in your own family routines, postponement of your plans, divided loyalties between your parents and your children, feeling you're spread too thin, and really the family history of any given family inevitably emerges. Every ancient sibling rivalry, every unhealed wound, every perceived grudge every conflict which has ever existed in a family, and every family has these, really will oftentimes reemerge with the stress of especially an extended period of time of dependency of a parent. So that is part of what oftentimes are issues that the caregiver must deal with. Ways to relieve stress for the caregiver include, I think, beginning with just acknowledging what a huge job it is to take care of and be responsible for another person. And it's an enormous responsibility. I think it's also important to realize that there's no way everybody will make all the right decisions, that mistakes will be made, misjudgments will occur, mishaps will happen. It's just inevitable. It's important to get a break from your responsibilities if they are intense. It's important to know where your supports are and to be able to call on your supports, and to know also that certain things really are out of your control. You will not be able to control every single thing that occurs, no matter how hard you try. Red flags for a caregiver are what you would expect: resentment, frustration, anger, testiness, distancing, sleeping, your own health challenges. Those kinds of things are clues, again, that if you are in that primary caregiving role, it's important that you step back, that you find a way to take care of yourself, because the other problem is then if something happens to the caregiver, then you really have a system breakdown. Just a few final thoughts. Sometimes it's surprising how a small fix can solve a large problem. In the past week, 2 people have said to me, one person said, "We didn't know Mother was deaf until after Daddy died." And they really, the husband had been doing the hearing in this system for really an unknown period of time. And so it dawned on them that, she hasn't been hearing for an extended period of time. That's fixed. She is in much better shape. Another colleague said to me, we really thought my mother was declining, but we just learned she can't hear. So they got her hearing aid. She's really coming back. There are small things sometimes that we don't push hard enough on. A lot of people resist having their hearing tested. Lots of people resist having things checked out. Sometimes, though, those small fixes are enormous. Those 2 instances are probably, had the hearing problem not been detected, those are women who would have been on a downhill slide, and everybody in their system would have assumed they were sliding down, and they would have inevitably gone along with the program. But so small fixes really sometimes have big impact. The Ready, Set, Go system also works a lot better than the Fire, Ready, Aim plan, and that is, without the planning, you really have oftentimes enormously important decisions to make in a very, very tight time frame. And lastly, this all sometimes sounds so gloomy to me, as though it's just going to be one trial after the other, but I see all kinds of really amazing things happen with families during this period of time. And in a way, how a family handles this stage of the life of an elder, it either strengthens a family or it doesn't, and oftentimes it really does. And I think if a family goes through this kind of thing deliberately, with their eyes open and intention, that people really can oftentimes emerge from this really better. Lastly, I want to just call your attention to a couple of things that are in the packet. I put a few of my sort of favorite articles in here, and one of them is called Breaking the Promise, and that is about breaking the promise that you'll never have someone go into a nursing home. Lots of people say, "I never want to go into a nursing facility, don't ever do that to me," et cetera, et cetera. And sometimes, and people who, if my mother said that to me, I would make the promise. But sometimes you have to break the promise. And there's an article in there which describes that. It's short, but it's illustrative of this issue. The next one that's in there is called Stressful but Vital, Picking a Nursing Home. And it's there's a lot of material out there about how to pick a nursing home. This is just sort of one of my favorites. The third one is called Old Age from Youth's Narrow Prism. And this is about how biased we are and how wrong we can be sometimes when we look at a situation. And if you have time to read one of these, read that one. There's a resource list in there There is a description of one of our programs at Kansas City Hospice called Passages, which is a counseling program, one session, 10 sessions, whatever's necessary. And one of the things that we do in that program is to work with families who are trying to make care planning decisions. So if you need a resource, that is one of several, but it's a little unique from many of the others. So I thank you. I thank Norman Elaine again, and we're taking questions at the end. So, Natalie.
Well, I too want to thank Mr. Polsky for inviting me to come and speak with you tonight, kind of a late addition to the program. But I believe that the information that I have to offer will more or less be a good segue from, or actually Elaine's information is a good segue into the information that I have. American Companion Care is an agency that provides caregivers to the elderly so that they can stay home safely for as long as they like. As long as we can do it safely, we'll keep them at home. So tonight, what I'd like to do is just to discuss some tips of planning ahead, because as Elaine said, often we in the caregiving business meet families who are in a crisis situation, and they have no clue. It's very often that I meet patients who are going home in the hospital, and they're being discharged with, medical equipment and oxygen and nurses and physical therapy, and I walk in and the family's eyes are like big as dinner plates. They have no idea what to expect. So it would behoove you to just kind of listen to the little tidbits that we're offering to you tonight so that you can prepare for an emergency if it should happen. First thing I want to discuss are the differences between home health services and private duty care. We're also going to discuss the differences between hiring a contracted individual or using an agency to provide your private duty services. I probably am going to sit the longest on long-term care insurance policy because it is a very valuable tool that a lot of people have and they misunderstand it. And then we're also just going to touch on the new and up-and-coming profession of geriatric care management. So I'd like for you to know the differences between home health services and private duty care. Home health services are directed by a physician. They're usually services that come into your home. The visits are kind of in and out, but the doctor is more or less in charge of the services that are going to be provided: nursing care, physical therapy, occupational therapy. He is the coordinator of all of that. But the visits that you will receive in your home are very quick. They're in and out. And it's designed that way. It's not necessarily a bad thing that the nurse comes in, she draws your blood, she takes your blood pressure, and she runs off to the next person. It's designed that way. Physical therapy will come in for 20, maybe 30 minutes for a session, teach you some exercises, walk you around, see if you're safe, and expect you to do the work while they're gone. They'll come back a couple days later, see what kind of progress you have made. These visits are designed to be in and out. Private duty care is a whole different animal. And private duty care is something where a caregiver can come in and assist someone who is infirmed or maybe recovering from a broken arm or a broken leg. They will come and stay for a long period of time. This is not covered by your medical insurance, which the home health services are. Private duty care is a paid out-of-pocket expense. So that's the primary difference between the home health services and the private duty care. Private duty can be covered by long-term care insurance policies. So if you have a policy, it would behoove you to read it and see if it would cover care for you in the home. I do want to mention, unfortunately, private duty care is expensive. We'll discuss that in a minute, too. But there are Medicaid waiver programs, so don't be dismayed if it sounds like it's something that is out of reach for you. I encourage you to contact your agency on aging. It's a county office a county agency, so you call that office, and they will help you determine whether or not you would be able to qualify for the Medicare waiver programs for the private duty services. Okay, now we're going to quickly discuss the agency hires versus private hires. Agencies offer screened, insured, and bonded, and experienced caregivers. So if you're hiring an agency for your private duty services, you can have that comfort and assurance knowing that this is not just someone who is unemployed and needs a job. These caregivers from the agencies are trained and they are experienced, and the agency is providing the insurance and the bonding so that you feel certain that this person is okay to bring into your home. Agencies also offer backup assurance if your caregiver, has an accident or has a sick child or wants to go on vacation. These agencies can offer backup caregiving for you. The company also handles the paperwork necessary for taxes. So if you're working with an agency that has employees, they will provide the W-2 for the employees so that you do not have to manage any paperwork for that. And they also, if you're working with a registry and the caregivers are independent contractors, the agency will provide them with a 1099. So it's just something you don't even have to think about. Those agencies will manage it for you. And they will also do your long-term care insurance policy paperwork as well. And that's a huge benefit. It's those hoops that you have to jump through for long-term care insurance are important, and you have to jump through them correctly. And I love long-term care insurance policies. I think they're fabulous, but they can be quite complicated, and sometimes having help is great. Okay, so let's get on to our long-term care. Long-term care insurance is the policy that will help pay for your care when you get, to a point where you need some care at home. There are many qualifiers for these policies for them to be activated, but in general terms, if you're needing assistance with 3 out of 5 ADLs, you will qualify. Or if you have cognitive impairment. Well, what the heck is an ADL? That's an activity of daily living. And those are the types of activities that you need to do to be able to perform just in a regular day-to-day situation. Can you eat by yourself? Are you able to transfer, which means getting in and out of bed or in and out of a chair by yourself? Are you able to toilet yourself? Can you dress yourself? Are you able to walk without assistance? So those types of things that people don't even think about. You get up in the morning out of bed, you go brush your teeth, you get dressed, you go down and have your breakfast. Can be very complicated. Sometimes as we get into a situation where we can't do those anymore, we need to have an assistance. Well, here we go with the complications of these long-term care policies. It's a problem, and it's getting better. I do want to say that. There is a waiting game. First step is you will have to be assessed by a designee of the insurance company, so you have to wait for that assessment. Then also you'll have to have an assessment and paperwork filled out by your physician. So that, take another week or so maybe. Then the paperwork is sent off to the insurance company, and they have to determine whether or not you actually do fall into that category of receiving those benefits. And then, those are just the types of waiting games that you have to wait for. But there again, this system is getting faster. More and more people are using their insurance policies, and it's flowing much more quickly. You also will have to wait for reimbursement of the services that you've received. So there is, it's just a waiting game. As I say, it's getting faster, but you need to be prepared if you need in-home care prior to that activation of that policy and payment of the benefit. You need to have a little bit of money, a little bit available to you to pay for that. So it's important for you to know your policy. There's some questions that you need to address when you find your policy, and I say find your policy because these policies were purchased a long time ago. I've had many family members say to me, well, I know Mom has a long-term care insurance policy, but I have no clue where it is. So find it first. And then after you've found it, determine whether or not if the services will be provided at home. Do you have to be in a facility to receive these benefits for the insurance policy? Is there an elimination period? An elimination period means you have to receive services for a certain period of time prior to activation of benefits. That could be 30, 60, 90 days. So find out what your elimination period is, if there is one. Who can provide the care? Can a family member provide the care for you, or do you have to have services from an actual agency, either a home health agency or a private duty agency? Can you use a contracted individual in your home that you choose personally? Can that person be the caregiver, and can you be reimbursed for those? Okay, the last thing I'd like to discuss is geriatric care management. This is a new and up-and-coming profession that I know you guys will be hearing about. Geriatric care managers typically are RNs or social workers who've had extensive experience with working with people who are infirmed or perhaps mentally ill. They help with insurance, and they help with resources, to provide resources in the home. They have a variety of resources available to them, and they have great problem-solving skills. Geriatric care managers, I recommend, should be certified if you're going to work with one. The certification process is quite extensive, and you can be assured that the person that you're working with has great experience, great resources, and is able to help you most effectively with the problems that may arise. Geriatric care managers do charge by the hour, or they charge a flat fee, so it is, there again, another out-of-pocket expense that you will be incurring. But if they're solving your problems quickly, often they can be less expensive. For example, if a geriatric care manager came in and assessed your home for safety, you can imagine that if the resources that you need, like handlebars or, maybe a slide to go up the stairs, a chair slide, those types of things to avoid a fall, you can imagine how complicated and expensive a fall would be. So they are very beneficial to you. So there again, I just want you to understand the differences between home health services and private duty home care. The home health services are paid for by your medical insurance, and the private duty care typically is an out-of-pocket expense. Agencies providing private duty services offer more support than contracting individuals in your home. Long-term care insurance is valuable, but understanding your policy is very important prior to needing it. When you need it, and you need to understand it prior to that. Find a geriatric care manager that can help you with your needs, and you will be assured that you're getting information from an experienced, certified caregiver. Thank you.
Well, thank you so much to all three of our speakers this evening. Let's give them all one more round of applause, please. And now we do have quite a few questions here from the audience. If you've not yet handed in your blue card with your question on it, the ushers will be coming around, and we'll continue to take those cards as we continue with the program. The first question for David: isn't it true that AARP will hunt you down when you're 49 and a half years old?
No. I
No
never
matter
know
where
how
you
they
go.
find that out, though, but it's a good question. I don't know exactly how, but you start getting that when you're 50, I guess.
Thank you. And this is our first serious question. Okay. How much will, this person calls it the Obama health care cost, and who will pay?
Well, I've told you several important things. It's going to reduce the deficit. It is going to save Medicare. There's a variety of ways that it's funded. Some of it is funded through increased deductions for things like Medicare. Some of it as cost savings. It's a very complex formula. Yes, we're going to be paying for it, you and I and everybody else, but its impact is going to be huge, and it's going to preserve Medicare. I mean, where else are you going to get health care when you are 65 and beyond? Nobody else is going to do it for you. Nobody else is going to offer it. I think that it will preserve Medicare. It reduces the deficit. I think, is it a good plan? Well, that's up for grabs, but I think it's funded through a series of cost savings and payroll tax deduction increases for certain high-income individuals.
Okay. This person asks, if there will be free preventive patient care, what amount will physicians receive for this service?
Oh, I can't tell you that. I mean, it'd be impossible for me to know what the physician receives, because if you go in for a colonoscopy, you know very well that there's a part of that's physician and part of that's hospital, and everybody else has a hand in that, so to speak. I can't say exactly what the physician will receive. I don't know, and I'm not sure that all that is set yet to this point, but I'm not that much of an expert to know.
Okay. Here's somebody who asks about if Kansas opts out of the health care plan, how does that affect people who want to buy insurance from the exchanges?
If they can, and I don't think they can, to be honest with you. It ain't going to fly. I've talked with constitutional law experts, it's going to be impossible. But if it does, those of you that, if you can't get insurance, you know where to go to complain about it, and that will be these people that have said, that we shouldn't opt out of it. There will be very little recourse if the state were to opt out of this. However, that being said, everything that I've looked at would say that it will be impossible for the state to opt out of it. And I'm not so sure. In fact, there was a bill. They tried to do that. They tried to, and it wasn't successful in Kansas. There was an attempt to get a ballot measure. There was an attempt to make some kind of a law, constitutional amendment in the last legislative session to force the state to opt out, and I don't think that got through. Some states are still trying it. They tried to get our Attorney General to sue the federal government over it, and he has resisted that. The benefit, this is huge. I mean, I got to tell you, there is a huge benefit to people, and particularly those that don't have insurance. I don't know what would happen, I guess, in response to your question. It would be a sorry state if that was to happen, I'm afraid.
Okay, this question is for Elaine and Natalie, really. You mentioned having the talk, and here's somebody that's looking for strategies on how to start that conversation with an aging person who refuses help when they very clearly need help. How can you have the talk?
Go ahead. I'll let you start.
It's very common. I mean, this exact situation is extremely common, where it's very clear that something's got to happen here, but there is enormous, frankly, denial and resistance around this. And I don't know that there's any magic answer to this, and I think that, people knowing who the person is that you're speaking with is very important. I mean, what works for me may not work for you. So how to begin a talk may be something as simple as making an observation. I can see that you are not doing very well. I am worried about the fact that you don't seem to be eating well. And I think you can fall back on every psychological therapist's advice of using I statements. I feel concerned about you, rather than you are in trouble here. I feel worried that you are going to fall. And you've started with an I statement. It's much less threatening than other ways into difficult conversations sometimes, but I think you just sometimes have to wade in and know that it may not, I mean, you may fail. You may fail the first time, you may fail the second time to actually get something to take. But I think being honest with someone, being as sensitive as one can to who it is that you're speaking with and their particular style of communication, but starting it with the I statement so that it doesn't feel accusatory or it makes it somewhat less threatening, I think. I don't know, Natalie, you may.
No, I agree with that. One strategy that I have found to be helpful, and you know, who knows if this would work in it wouldn't work in every situation. But for example, if you went to the community, the religious community that this person may use, or to their lawyer, there are always documents and papers available in these offices and communities to prepare for the future. So if you just gingerly say, I saw Mr. Smith, you know, and I went to talk to him, and he had this packet of information, I'd like to review it with you. And just see if you can start that conversation that way. I know a lot of churches and have packets of information that you can present and just say, you know, I found this at the church, and, you know, I think that we ought to sit down and at least look at it together and just see if that will open up the conversation for you.
Okay, thank you. Elaine, here's somebody who asks about hospice. And when does hospice become involved in a situation with health care? Do you have to have a terminal illness?
You do have to have a terminal illness or a life-threatening illness for hospice to be involved. The Medicare rule for hospice is you are eligible when your prognosis is 6 months or less. Unfortunately, we see very few people for as long as 6 months. Hospice is usually called in way, way late, days or weeks. And I must say that denies people an enormous amount of help and support and guidance when hospice is delayed until the last few days or weeks of life. But one is eligible for hospice when a prognosis is 6 months or less. Doesn't mean the patient's going to die in 6 months. Hospice has no control over that, but it does, I would encourage people to accept that kind of support as early as possible, and also to understand two other things. One, hospice is not a one-way street. You can start hospice and stop it. You can start it and stop it over and over and over again. So once you are receiving hospice care, it doesn't have to continue forever. A second thing that I would like people to understand about that is hospice actually has been shown in research studies to extend life. And it's not really rocket science when you think about it. So, because what does hospice do? It comes in, it looks at your medications, very good at pain and symptom control, very focused on quality of life issues, lots of support for your family and for you. So the system calms down. And the research shows that hospice care often extends, it doesn't reverse the course of illness, obviously, but it does and often extend life by a matter of weeks in controlled studies.
Thank you.
Now, one other comment, if I may. Palliative care is hospice's sister. And palliative care, palliative home health care, we have a program called Palliative Home Health, is a program very similar to hospice, but without the prognosis requirement. We realize in hospice that you really shouldn't have to have a prognosis of 6 months or less to get really good symptom management, really good education, really good support for your family, et cetera. And so we have opened a program which provides the same sort of services, but upstream in the illness.
Thank you. Here's a question going back to David regarding pre-existing conditions. Before 2014, when the exchanges become available, do you have any idea how expensive those high-risk insurance pools might be?
Well, yeah, the high-risk insurance pools, in fact, they already have those in place, are very expensive. and I can't tell you how much, but they are expensive. They're being made available. There are some controls in place to control some of the cost of them, but that's really only a stopgap measure till 2014 when the exchanges really kick in and there's a lot of controls in place. I don't know how much the exact dollar amount is, but they are certainly a source of some insurance regardless of your pre-existing medical condition, but they're only stopgap, only for at most a couple of years.
Okay. And while we're on exchanges, here's someone who asks, are they run by insurance companies even though they're state-sponsored?
No, the exchange, the marketplace, if you will, is run by the state. The insurance policies are private. In other words, look at it, the exchange as a marketplace. It's a marketplace you go to and buy your insurance from private companies. What the exchange does, it sets up a mechanism where you can compare side by side the cost and the benefits of and the exclusions, if any, of each of those policies. There are certain things that they can't do. In other words, they can't discriminate against you if you have a pre-existing condition. They can't discriminate because of your gender, for instance. So those are the broad perspective. It's a marketplace, but the companies that provide it are private. It's not government run. Until you get into, obviously, Medicare, that's a different kind of a program. But the exchanges are private. It's a marketplace. A good example is if any of you are on Part D for Medicare Part D, the prescription drug program, you know you go in there and you put into the computer the different drugs you're taking, and you can look side by side at all the different policies that are available from private insurers. It's the same kind of a thing.
Okay. Here's somebody who says, why can't we just eliminate the donut hole right now?
Well, yeah, we fought for that, but, you know, it's a money thing. And a lot of what happens in these bills, and what came out of the bill, is not all of what we really wanted, but it was, you know, the best we could do. We knew we needed to close that donut hole. It was really paramount for a lot of people that we close the donut hole. We just couldn't get the money to do it right away. It had to be phased in, and that's just something they had to do.
Well, this is a provocative question, and so it's a toss-up as to who wants to answer this one, but somebody's asking, what feature of the health care bill was referred to as the death panel?
I'll take it.
Okay, then I'll follow up. Go ahead.
What was originally referred to as the death panel is not in the final bill, so the final bill has nothing related to this. What it was a provision in the House version of the bill, again, didn't carry through, which would pay your physician to have a conversation with you once every 5 years about what your end-of-life wishes were. That conversation would be, do you have an advance directive? Do you want aggressive treatment? What if this should happen? What if that should happen? That is all it was. And that was exaggerated into something called a death panel, which was, I have no idea where that even idea came from, but that's what it was, and there's nothing like that in the current, in what passed.
Never has been, never was from the onset. The original idea was basically a very good idea. It just it allowed you to file for a benefit, to pay your physician to have a conversation with you if you wanted. It was all optional. And it got twisted and turned by those who didn't want to see this happen.
Thank you. Here's somebody who is a caregiver who's asking, when you're working full-time and you have both your parents and your children and yourself to care for, and you're feeling the guilt of not being all those places at the same time equally, how do you handle that kind of guilt feeling?
You start.
Well, whoever you are, you're doing a fabulous thing, and you have all of our support and sympathy. It is a very, very difficult thing. I think that it's important to have a set of realistic expectations of yourself. There really is only so much any one human being, no matter what superwoman or superman it is, there is only so much one can do. So I think understanding that and having a realistic set of expectations of the universe of the possible is an important part of it. I think sometimes one of the things that, we give caregivers all this advice about getting plenty of, get exercise and take care of yourself, and it's really, when I was in the caregiving role, I really rather resented it, frankly, because I barely had time, to make coffee in the morning, let alone go, for a walk around the block. So generally, I don't think that's really a helpful piece of advice. But I do think having realistic expectations, and I do think trying to identify where you can go for support is important. And, even a once-a-month conversation with a counselor will make a huge difference to someone in that situation. You just shouldn't try to row the boat alone.
I would have to agree with that. Guilt is a horrible thing, and if you can find just a network, a person, a psychologist, a friend, a support group that you can just talk with and realize that you are not Superman and you cannot be everything for everyone, but you can't be anything to anyone if you don't take some time to yourself.
Thank you. Here's a question about nursing homes. And are there agencies that rate nursing homes or that examine nursing homes and can make recommendations, both good or bad?
Well, there are nursing homes, and again, that's a pretty broad topic. We refer to nursing homes, yet senior communities might be a better word, because there's different levels of care. There's independent living, there's assisted living, there's skilled care, there's dementia care, there's assisted living dementia care, there's skilled care dementia care. There's a lot of different levels of it. Those facilities which provide a measure of care, the assisted living and the skilled care, whether dementia or not, are very heavily regulated. They're inspected by the state. There is an inspection process which is open to the public. And if you go to Medicare.gov, you can look up the results of those inspections and see that information as to what kinds of things were found in these inspections. And you can possibly look at trends. So it's a compilation of inspection reports that are required. Now, if you get into things like independent living, they are not regulated in the same way, and they don't have the same kinds of inspections. So you have a tougher time finding out information about that. But all the regulated facilities are available at Medicare for you to look at and interpret. There's also an organization called Kansas Advocates for Better Care, KABC, that's in Lawrence. They put out a regular publication. They're advocates for residents of senior care facilities, so that you can contact them, go to their website, you can make a donation. They have a nice newsletter that they send out periodically to help provide that kind of information for you as well. So I would encourage you to look at those resources.
Thank you. Well, here's someone who's a retirement community advocate who says, we've put a lot of emphasis on home health care, but there are wonderful caring retirement communities in the area that offer continuous care when you become seriously disabled or ill, and you have friends there and they'll help you with your health care, and so sometimes that's a really good option for people.
Yes, and I think that, people do like to stay in their own home, but some people like the communal living, they like the interaction, the activities that are available. And, the thing of it is, there are places where you can go when you have the extreme medical conditions, when you need help and you need that around-the-clock care and you need that kind of very intense kind of care, or dementia may be involved. They have some wonderful programs out there. They also even have daycare programs, which is something else that we haven't talked about, but which it's valuable.
Okay. We just have a minute or two left, and I want you to know that there are a lot of good questions still remaining here. I think our speakers are willing to stay after the program if you have a very specific question that you'd like to ask about recommendations for a long-term care policy or those kinds of things. So if our speakers are willing to do that, we can meet them in the lobby and have coffee and a cookie and have a little conversation. So thank you so much to David Wilson, Elaine McIntosh, and Natalie Schneider. Norman has a question. Yes.
I want to thank David. This is what his PowerPoint and what you have, this booklet by Aarp. I've seen the piles of paper, legal papers that are about 2 piles, 1 foot deep. This is the first time anybody showed the benefits of all publications. Nobody, Wall Street Journal or anything.
Right. In case you can't hear Norman, what he's saying is he's thanking David for the AARP presentation because of the 2,000 pages in the healthcare bill, the 2 feet tall pile of paper that was there. This is the first time Norman really felt like he got a good overview of the basics, and he feels good about what he's hearing. So thank you, David, for doing that. We appreciate it.
Thank you.
And thank you to Elaine and to Natalie very much. Please turn in your green cards on the way out. Pick up a book in the lobby, and please join us for a refreshment, and our speakers will be happy to speak with you. And come back and join us for Adam Bold on June the 2nd. Thank you for coming.